ఇండియన్ మెడికల్ అసోసియేషన్ తిరుపతి జిల్లా అధ్యక్షులు ఆర్ఆర్ రెడ్డి, సెక్రటరీ శ్యామ్, ట్రెజరర్ రెడ్డప్ప వారి యొక్క ఆధ్వర్యంలో తిరుపతిలోని ఇండియన్ మెడికల్ అసోసియేషన్ సభ్యులు అయినటువంటి డాక్టర్లందరూ ఈ సమావేశం నందు పాల్గొన్నారు. ఈ కార్యక్రమంలో ఎంఐఓటి హాస్పిటల్ చెన్నై హార్ట్ సర్జన్ డాక్టర్ ప్రదీప్ కుమార్ హార్ట్ అటాక్, గుండెకు సంబంధించినటువంటి ట్రీట్మెంట్ ని ఎలా అందించాలి అనే అంశాలని ఈ కార్యక్రమంలో మాట్లాడటం జరిగింది. అనంతరం ఇండియన్ మెడికల్ అసోసియేషన్ తిరుపతి జిల్లా అధ్యక్షులు అయినటువంటి ఆర్ఆర్ రెడ్డిని డాక్టర్ వాకర్స్ ఇంటర్నేషనల్ ప్రెసిడెంట్ మరియు మాజీ అధ్యక్షులు డాక్టర్ రవిరాజ్ వారిని ఘనంగా సన్మానించడం జరిగింది. ఈ కార్యక్రమంలోని డాక్టర్ దామోదరం, డాక్టర్ వరప్రసాద్, డాక్టర్ శ్రీహరి నాయుడు మరియు జూనియర్ డాక్టర్లు పాల్గొన్నారు.
Dr. R. Pradeep Kumar Garu. Actually, he's from Barampur, South Orissa. Dr. R. Pradeep Kumar, he did his MBBS, MD and DM Cardiology, CMC Vellore. Total, motto, everything. 2004 MBBS, MD General Medicine 2010, and by 2016 DM Cardiology from CMC Vellore, which is a prestigious institution of India. FSCA, International Associate, American College of Cardiology. Actually, he did his, and his past experience, ex-assistant professor, the Department of Cardiology, CMC Vellore, and ex-HOD, Cardiac Sciences, Jaiprakash Hospital, Rourkela, and his actual field of interest, complex coronary intervention and structural cardiac intervention, and heart failure, and in field of special interest in heart failure management. He did his research area of interest in artificial intelligence in cardiology. Actually, I am very glad to introduce in this meeting, sir. We are glad to hear what your experiences and in management of heart failures in today's the topic. So, thanks, sir. Sir,
15-20 minutes or half an hour basis monitoring. Patient will start improving within 2 to 3 hours. What I have seen with this one. But the moment BP drops, we need to stop first vasodilators. Then comes vasopressor. Vasopressors are the same noradrenaline. Then diuretics if perfusion is restored. Never initiate diuretic or Lasix or infusions if patient's BP is less than 80 systolic, because BP will further go down and organ failure will result. So if BP is a little supportive, more than 90 or more than 100, then only we need to initiate diuretics. Before that, we need to think of inotropes. Then last, if nothing is responding to the therapy, mechanical circulatory support, MCS. That I'll come to in the last part of my talk. What are the mechanical circulatory supports? So this is another same thing, whether cardiogenic shock is or not, because this is the most important thing which will kill the patient. Cardiogenic shock. If there is a cardiogenic shock, we need to think of circulatory support, either pharmacological in the form of noradrenaline or dobutamine, or if not, then we need to think of mechanical circulatory. But if patient doesn't have a cardiogenic shock, then we have to think of whether patient has a respiratory failure is there or not. If patient has a respiratory failure, first we need to think of ventilatory support. Nowadays, most of the hospital after COVID era, they have the ventilatory supports with NIV at least, non-invasive ventilation. The moment patient comes with a pulmonary edema with respiratory failure, he will respond to this non-invasive ventilation with diuretics. So we need to assess whether patient is in risk of first. If there is no shock and the patient has a respiratory failure, straight over he presents with accelerated hypertension and leading to LV failure or biventricular failure. Third thing is arrhythmia, whether any VT or ventricular fibrillation is there is going on or what, or supraventricular arrhythmia at times also may, in presence of LV dysfunction may cause failure. Third thing is acute mechanical cause. Mechanical cause, there are three mechanical causes, especially in acute MI patient. Left ventricular free wall rupture leading to tamponade. Second is ventricular septal rupture, the septum between the right ventricle and left ventricle. Third is papillary muscle rupture leading to acute MR. All these three mechanical complications have a grave prognosis. I have seen only one person surviving in my life, otherwise they have a very grave prognosis. Unless these are tackled with some IABP or immediate surgical intervention. Otherwise it is very difficult to tackle. But nowadays mechanical circulatory support has come. With this surgeons are claiming we are getting good results. But in my experience I have not seen, but surgical team they are saying the moment we refer them they are treating with the circulatory support and keeping them stabilized and reviving them. So first what I need to say is we need to, the last one is a pulmonary embolism. This is another example, acute diagnosis where it responds to, is in shock, he will respond to thrombolysis. Nowadays even in the earlier days it was streptokinase, nowadays we have tenecteplase. The moment you just inject one bolus of tenecteplase, patient will have improvement within 2 to 3 hours. N number of patients I have treated with acute pulmonary embolism with just tenecteplase and the patient will be out of ventilator within 1 or 2 days. I mean, it's a wonder therapy of acute pulmonary embolism. Even this is much, nowadays all interventional radiologists they are claiming to be doing interventional therapy. But if you have a tenecteplase, just inject a tenecteplase and see the response within next 2 to 3 hours. Definitely patient's BP will improve, saturation will improve, and overall patient's sensorium will also improve. The patient is in shock. So these are the champ is the like 5 things. These are 5 things are treatable causes, but except the mechanical cause, all rest all are like treatable causes. So then comes we have to think of the congestion or the crepitation. We have to hit hard then and there. Why? Because if we are shifting the patient out of ICU or we are discharging with congestion, there is a 50% possibility patient will get readmitted within 10 days or 2 weeks. So physical signs of congestion like crepitations, edema, or raised JVP are absent in about 40% of the patient. We usually think of the congestion means this is a classical teaching like pedal edema or ascites or raised JVP or crepitations for LV failure. But these things are absent even if in 40% of heart failure patients. And 20% of patients with congestion exhibit normal chest X-ray. Another thing what we do chest X-ray we will see whether the pulmonary edema is there or not. But about 1/5 of the patients will have a normal chest X-ray. So the only tool to diagnose such thing is the lung ultrasound. But again we have to rely on the radiologist. It's availability of radiologists to calling them the bedside is a little difficult challenge in acute setup. So lung ultrasound is better in ruling out the interstitial edema and pleural effusion. And this detects how they diagnose the curly B lines. So if there are more than 3 B lines in more than 2 intercostal spaces, then it's one of the diagnostic criteria for acute heart failure. But we have to over the period of years, I mean those who are into intensive care unit, intensivists, they have to, they usually now started they doing. So most of them we take the help of the intensivists rather than radiologists. It's difficult to catch them in the acute scenario. The heart failure acute dose AHF study. Why? Because once this is not a euvolemic, patient will come with again heart failure or hospitalization. And clinical congestion at discharge is a strong predictor of poor outcome for readmission. And relief of dyspnea is a poor marker of decongestion. We should not never go with the patient symptom. If patient is asymptomatic, that means it's not like a sign that patient is fit for discharge. We need to think that patient is fully decongested. How to know the decongestion? One of the best criteria, if these features are there, then only patient is fit for discharge out of hospital. So what are these things? JVP, if JVP is not elevated, means that's absent, less than 8 centimeters. There should not be any hepatomegaly and there should not be any pedal edema. And 6-minute walk test, 6-minute walk distance should be, ideally it should be less than 400. Even if up to 400 is also fine, acceptable. NT-proBNP, this is nowadays available in most of the places. If NT-proBNP should be less than 400, but in my practice I have seen even if it is less than 1800, you can accept it. Up to 400 is assuming is a very difficult target. needs to a longer duration of hospitalization, but not a very strong criteria. You can optimize the thing over in a OPD. Back with again acute heart failure. So that's why this is important. And patients with readmission for cardiovascular disease within 90 days or 3 months of discharge of heart failure hospitalization have a higher risk of mortality. Why we look into this registry is because from there we get the inference or conclusions, so that how to registry. And this is reported from 108 centers from 6 geographical regions all over the world. And overall 1 year mortality among the heart failure patients is 16%. And the highest mortality is in Africa, second is in India. 34% in Africa, third 23% of mortality is in India. And average mortality in the Southeast Asia is 50% among the heart failure patients. But surprisingly, the lowest mortality is reported from China and other countries. Cold wet. Wet means congestion, means 90 or most range at less than 80. So shock means cold, wet means crepitation, dry means patient has no crepitations, no shock. Okay, that is warm dry, which is one of the best prognosis. But patient will be having a heart failure. Comparing cold means patient is in hypotension or blood pressure is less than 90. Dry means patient is machine. Get the echo in the ultrasound just in the IVC here in the epigastric region, put it in a vertical way and see the IVC collapsibility. And decongestive therapy is similar for both the reduced ejection fraction as well as the preserved ejection fraction. Goal of therapy is to achieving through decongestion without any residual volume overload. There should not be any congestion, and ensuring adequate perfusion pressure to guarantee organ perfusion. Dose AHF trial, there is no difference of primary endpoint between the continuous or bolus infusion. Though this study shows this dose is AHF, but in my practice I have seen continuous infusion of Lasix at 2 or 3 milligram per hour usually makes a huge difference in the first 24 to 48 hours. So usually still now we are preferring that same practice of giving a bolus furosemide 20 to 40 milligram followed by IV infusion for first 48 hours. In dose AHF, what they have done, they have not given the bolus dose. Without bolus Lasix, they have just continued the infusion. That will not work. Always start a bolus infusion, bolus injection of around 20 to 40 mg stat, or if amount of pulmonary edema is too much, then you can go up to 80 milligram of furosemide or Lasix stat, followed by infusion 2 to 3 milligram per hour. This is a brief, to revise our old memories, which drug acts where, which diuretic acts where. So, this is a nephron with, this is a proximal convoluted tubule. Usually about 65% of sodium reabsorption happens here in the proximal convoluted tubule, PCT.
स्मरामि महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि वसिष्ठवामवेदान्तिवन्दित महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि महागणपतिम् महादेवसुतं गुरुगुहनुतं महादेवसुतं गुरुगुहनुतं वामदेवादिवन्दितं महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि महागणपतिम् महादेवसुतं गुरुगुहनुतं महादेवसुतं गुरुगुहनुतं मारकोटिप्रकाशं शान्तं मारकोटिप्रकाशं शान्तं महाकाव्यनाटकादिवन्दितं महाकाव्यनाटकादिवन्दितं मूषिकवाहनमोदकप्रियं महाकाव्यनाटकादिप्रियं महाकाव्यनाटकादिप्रियं मूषिकवाहनमोदकप्रियं महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि महागणपतिम्. Okay, thank you.